The first one is a great one for you. It dovetails into one of the lingering questions that I had from last session. And for somebody with like mild hip dysplasia that also perhaps has some element of impingement, what are the similarities and differences that you see on your end after they've been through a scope versus a PAO? Like, is this night and day? Are they similar? Or how do you think about that?
That's a good question. I mean, if you're looking at a mild dysplastic who goes through a PAO versus a labral repair osteochondroplasty, they do set up fairly similar. Waiting time for weight bearing, similar precautions. You want to be careful with the hip flexors, post-operative management, the scar tissue management. So they very much stay the same, except PAO is maybe a little bit longer, especially on the more simple procedures. I mean, that's not a simple procedure, don't make me say that, but just the ones that aren't, having pain for 4 years and they're centrally sensitized and their nervous system doesn't know which way is up and their pelvic floor is shot and the core doesn't work. Those guys are a different beast. But the ones who are pretty, like the borderline, I would probably say that how long they've been dealing with it, how often, if it's a more acute thing, talking about more like a year or less, they seem to do better, more like a regular old hip scope. That's the way I'd answer it.
Yeah, I think that is completely congruent with what I've seen in my practice, meaning, there's data to support that, which is if somebody has an operation, a scope or a PAO or both, and they have a limp before surgery or they have muscle weakness, which coincides with what you just said, they've been dealing with this for a long time, and they're decompensating, then their recovery, like recovering in that situation is definitely possible. It just takes a lot longer than somebody who comes in to get treatment right away.
Yeah,
The flip side to that is like, should we be more aggressive in recommending surgery right away for everybody that comes in the door? No, of course not. I think there's a huge percentage of people that get better with the right therapist pairing. So it's a sticky balance between waiting long enough to be sure that we've exhausted non-surgical things, and then also jumping on board, jumping into surgery, and then having the appropriate recovery afterwards to help before weakness and limps really become a major issue.
Yeah, that's a great question, because I see patients who've had it for a long time and they're like, should I have done this earlier? And it's like, well, the trouble is you probably have borderline dysplasia on the other side, and that may last you till you're 65 or till the end of life. Who knows? We don't definitively know. And I know there was a time that surgeons were doing some prophylactic surgeries, and it sounded interesting, but it's just too complex a surgery, especially the PAO. But I would probably say it should be a more common surgery because of the sequelae of it beats up the labrum, especially the borderlines that are a little less obvious. Beats up the labrum, then they have this labral problem, and then the labral, the hip arthroscopist says, oh, we could do this, but you have this shallow socket. But back to your point, these are the patients you have to go really hard, rehab, get the rotators working, get the glutes working, get the core firing, dissociation, and teach them that maybe it's not a good idea to do hardcore yoga and bend like crazy, and give some time. So it's a good thought.